Hi, everyone. This is Beth with the Lifestyle PA podcast. Today, I spoke with Elizabeth Peckham, who is a cardiovascular nurse practitioner, all about heart disease, which is the number one killer of women. We dove into what the latest trends are in women that she's been seeing in practice, talked more about the bad cholesterol, LDL, and blood pressure, the silent killer, and what we as women can be doing to decrease our risk of this really scary, prevalent condition. Elizabeth is currently practicing in Connecticut. She worked for several years as a cardiovascular nurse before completing the Family Nurse Practitioner program at the University of St. Joseph's, and that was back in 2016. She then worked for a cardiology practice in Springfield, Mass. For 8 years before pursuing a leadership role. She's currently the lead advanced practice provider in the East region for Hartford Healthcare, overseeing 12 cardiac mid-levels. She maintains an outpatient clinic, she rounds in the hospital, and most recently helped build the cardiac PET CT imaging program. And she is currently working toward her doctorate in nursing practice at Quinnipiac University. In her spare time, she enjoys spending time with her 8-year-old son, Maddox, two dogs, Lucy and Murphy, and coaching baseball. So please join us as we have a great conversation surrounding the number one killer of women, which is completely preventable, heart disease. Welcome to the Lifestyle PA podcast, where we talk about all things women's health and lifestyle to help you become the healthiest and happiest version of yourself. So, as women, we automatically assume the number one killer is breast cancer. Like our mind goes right there. And it's actually heart health. 1 in 5 women die of heart disease. Back in 2021, 310,661 women in the US died of heart disease, a completely preventable disease, over 300,000 women. And that's shocking because there are so many lifestyle behaviors and factors that we are in control of that we can mitigate to help decrease that risk. And today, nearly 1 in 2 women are living with heart disease. About 50% of women have high blood pressure. Having high blood pressure, that increases the risk of heart disease, stroke, kidney failure, dementia, and early death. And most importantly, as we were mentioning, certain conditions and lifestyle choices increase your risk for this. So what I'm going to ask Elizabeth to touch upon, so things like bad cholesterol, right? Like the LDL, being overweight, having an unhealthy diet, that lack of physical activity, too much alcohol consumption, and of course, smoking and diabetes. Those are all major risk factors that are preventable in our world that we can do something about to decrease the risk of us as women developing heart disease. So, Elizabeth, if you wouldn't mind just kind of telling us, in your several years of practice, what are the trends that you've been seeing with women's heart health? What, from a provider's point of view, like what are your major concerns with women?
So, Bethany, thank you so much for that amazing introduction. I appreciate that so much, and thank you for having me on your podcast. The biggest thing that you're noticing and that everybody's noticing is everybody's getting younger and younger. That population of people needing a cardiologist later on in life, men and women, but mostly women, is happening at a much earlier age than what we've seen even 10 years ago. That's part and due because you have more diagnostic testing capabilities, more lab work being ordered, but this population is getting younger. A lot of the things that we're seeing in these young women are those elevated LDL levels. A lot of misnomers and miscommunication from providers all over the place with these women just really not knowing how to treat themselves. They really don't know how to get themselves an exercise regimen or what diets that are safe or not safe to follow, or even have somebody build a program for them to be able to be tailored to them. So that's why somebody like yourself doing what you're doing and helping women by building a program and showing them that they can make all of these lifestyle changes or these lifestyle modifications to support their heart health, and not only for their heart health, right, but for all their other organ systems, is so unbelievably valuable and important for women moving forward. I think that you're starting to see that coronary disease is happening earlier. You're seeing women a lot earlier in life, perimenopausal and even menopause, shortly after menopause starting, coming to the office for consultation in regards to their health.
Thank you so much for that. And so In your opinion, I mean, one of the things, and again, you can speak to this just based on your experience from the past several years too, is in my first episode, I talk about one of the reasons, like kind of why I shifted away from the standard healthcare system and why I'm doing what I'm doing. And it's because we have that pressure, and especially you as a specialist with the many hats you're wearing, like you only have a certain amount of time with those patients face to face. So how are you supposed to get across like all of the lifestyle recommendations and customize it and personalize it for them to feel comfortable then moving forward and implementing? And it's hard because change takes time, right? And you get what, 15 minutes with them and then see them at a follow up maybe 3, 6, 12 months down the road, right?
Correct. Yep. It's the pick three, talk about two mentality. You talk to your patient and you say, pick the three things that are going on right now, or pick the three things that we need to address. We're going to talk about them. We're going to discuss what we're doing between the next office visit. But you're absolutely right. Those lifestyle modification tactics, tools, resources that you have to be able to give the patient are not always available in 15 minutes. So you have to choose for your patient individually what's best for them at that time with the time you have.
Exactly. And then so with just because we started to touch upon that like bad cholesterol, right? The LDL,
Mhm.
because many of the women that we're speaking to today, they get their annual blood work, which hopefully will include what's called your lipid panel, which has those different types of cholesterol. And the one we're most concerned about is that LDL, the artery clogging, the bad one that increases your risk for heart disease. So can you give us a little bit of guidance on what is a concerning level? And if it's
Mhm.
elevated, typically how much time will you give one of your patients to allow them to try lifestyle implementation and changing those behaviors first before you recommend something like a statin? Like when should they get a little more aggressive about it?
So I love this question. I think this is excellent. I think a lot of people don't discuss the lifestyle changes first and really push medicines. And I am all about the lifestyle modifications and giving the patient the ability to try first before giving them a medicine. So if I have a female that comes in that has an LDL, now we're looking at the whole lipid panel. We look at total cholesterol, we look at HDL, which is your good cholesterol, your triglycerides, and we also look at LDL, which is your bad cholesterol. And triglycerides are synonymous with fat in your diet. So the misnomer is that the total cholesterol is what a lot of people look at, which is a number that you want to see less than 200. Your HDL, which is your good cholesterol, we want that greater than 40. Exercise really promotes that HDL for going up. So that's something that we recommend to our patients to continue to exercise and bring up the HDL as that lowers your LDL. Triglycerides, we would like that number less than 150. Your LDL changes based off of what your comorbidities are. So if you're a 40-year-old patient that comes in, you have no comorbidities, and LDL less than 130 is completely acceptable. Start to throw in high blood pressure, diabetes, we want that less than 100. Comorbidities on top of that, such as coronary disease, AFib with coronary disease, diabetes, we're very aggressive at that LDL being less than 70. That is something that we really hone in on. So if you don't have comorbidities, if you don't have other significant risk factors for coronary disease, I will absolutely give you the trial of diet and exercise. Follow the Mediterranean diet, eat fishes, eat nuts, eat less fatty foods, make sure that you're cooking with the right oils, get rid of butter, all of these recommendations to patients. Repeat a lipid panel in 6 weeks. If we give it what I call the good old college try, where we've tried diet and exercise and those LDL numbers don't improve, your LDL still remains elevated in the 140s, 150s, we might try a low dose, mild intensity statin therapy, such as pravastatin or simvastatin. So I will say these recommendations change if you have comorbidities. If you have coronary disease, you come in with an LDL of 140, I might not offer you that diet and exercise to start because you've already had an event, right? So are we trying to prevent event? Are we trying to prevent a recurrent event? Or are we just having preventative medicine? So I might say at that time, we'll start a moderate intensity statin therapy, but that is not a replacement for the dietary behaviors that need to happen, for the lifestyle behaviors that need to happen.
Yeah. And I think those are all excellent points. And it just further proves like this is so individualized. Like you can't just look at the numbers on their lab work and be like, yep, this is your plan. Yep, I'm going to give you this dose of. No, it all depends on the other health conditions, like you mentioned. Like, are they diabetic? Is their blood pressure elevated? Right. And I feel like we have two different groups in our world. Like you do have a group of women who are like, yeah, just put me on the medication. I'll do whatever's easiest, right? And not change a thing, which isn't
Mhm.
optimal. And then you have actually another group of women who are super hesitant and looking to avoid medication altogether. But in some cases, you really need that. Like it's beneficial. So it's also kind of getting the message out there like, this could be life saving for you. You know what I mean? Like in 10
Mhm.
years from now, starting a low dose medication and then working on, in conjunction with it, all of those lifestyle behavior changes, the nutrition changes, and then having a goal to either decrease your dose or get off it altogether. That's great. But I don't think like what I'm sensing from a lot of women is fear to get on this statin. Oh, because I've heard of muscle cramps. Oh, because I've heard of this. And I think you really need to weigh the risk and benefits and combine it with lifestyle therapies, and we'll try and achieve those goals. Obviously, genetics plays a huge role. And I'm sure, have you seen the small percentage of a population where you've had women come in, they are avid exercisers, they eat ridiculously healthy, they've done everything. They're on an omega-3 supplement, they have 30 grams of fiber a day, but their LDL is still high. Can you speak to what that would look like?
Yeah, so that does happen, unfortunately, and that is familial hypercholesterolemia in a lot of these patients. Some of them you can control them with what are PCSK9 inhibitors. So these are medications that are injectable cholesterol agents that you give every 2 weeks that are very, very aggressive at lowering the LDL, raising the HDL, and improving your total cholesterol numbers as well. The way these medications work is they attack the molecule before the statin, right? So these act before the statin can be effective, but the statin is not something that you remove from that combination of medications. You continue the statin with the PCSK9 inhibitors. So this population of patients, you're also really, really aggressive at making sure that those numbers are lower, but a lot of them have already had events, and it's unfortunate, but that happens. So we really try to treat these, you don't really have lifestyle modifications that you can give them because they're already doing everything right. But these are the people that need more aggressive treatments and sometimes have to be referred to lipidemiology clinics to be able to find out
Yeah.
other ways, or maybe they need apheresis or other things to be able to get these numbers down.
Wow. Okay. So those are the kind of like extreme cases that you'll see where
Yeah,
it's
those are more of
difficult
the
to
extreme.
manage. Okay. I want to ask you a few questions then about blood pressure because that is definitely a
Mhm.
silent killer as well. But to kind of wrap up on the bad cholesterol side. So, if an otherwise healthy woman comes to you and
Mhm.
their bad cholesterol, triglycerides, they're a little bit elevated, can you give us like your 2 to 3 main tips for lifestyle changes, like things that they can implement today that can hopefully decrease their
Absolutely.
risk and they can improve those numbers?
Absolutely. So daily walking is so important. And that's not, oh, that's 30 minutes of exercise, what I call a little pep in your step. So that's not 30 minutes of just walking on a flat surface. That's 30 minutes of trying to get your heart rate up. And it's something that easy you can do. I even let patients know instead of, taking the elevator at work, take the stairs, go up 2 flights of stairs, get that cardiovascular work in. Changing butter is one of the biggest things that I have found that's been very, very successful. Telling patients to not use butter when they cook eggs, when they cook chicken, when they cook anything, and replace that with an olive oil, a light-based olive oil, and then wipe out the pan with a paper towel first so that you're soaking up that excess oil and really only cooking with what you need to cook that food in. That's just unnecessary fat that you're getting, and then also losing the cholesterol with the butter, which I think is really important. So I focus on a Mediterranean diet, which is something I know that you review at length with your patients as well. I focus on low impact cardiovascular exercise with daily walking, and then I find out from the patient maybe something that they enjoy, and I try to tailor either an exercise regimen or a lifestyle modification to something that I already know fits in with their daily life, because that is the easiest buy-in that you'll be able to get with your patient.
I love that because it's realistic and attainable, right? Like so many women are like, yeah, I know 150 minutes a week of exercise. And they're like, I don't want to go to the gym for an hour. And I get that. Like not many people do. Like that's a big jump if you haven't been active already. So I love how you emphasize like it literally is just small changes, like a walk for 30 minutes, take the stairs, like any movement is beneficial. Like you don't have to go do a 60-minute high intensity interval class at a gym. Any movement will help. Last question for cholesterol. Can you tell us fiber? Insoluble, soluble, do you recommend patients like take a supplement to be easier, or do you really try and push like those whole grain, high fiber foods?
Whole grain high fiber foods, I think, is really the best way to go in regards to fiber. And the reason for that is because it's really less prevalent that I get that healthy 40-year-old woman that comes in that really only has those high triglycerides or high LDL that I'm managing. A lot of these patients have higher comorbidities. The more medications that they're on, the more difficult it is with polypharmacy and getting them to be compliant with medications and taking extra supplements. So if I can try to tweak something of what they're eating or add something into their daily life that's not an extra pill, because nobody wants another pill or another supplement to take. And sometimes some of these supplements can counteract with some other medications that they're on. So you have to be individualistic and mindful with what medications or what supplements you're recommending. So I would say fiber through diet is the most important thing, but insoluble fiber also has been known to decrease the LDL as well.
Perfect. Thank you. And then one other major dietary change that I know you're with me on because you've lived this way your whole life is really not even necessarily avoiding completely, but if you can limit your red meat intake and even just start limiting it to like no more than once a week, like that scientific research, if anything, we continue to learn more and they're proving more and more the link specifically between red meat and heart health. So I feel like just to add, if that was one other change, simple change for people, is start off by no more than once a week. And ultimately, even if you can decrease it to like once every other or once a month, that would be really beneficial for heart health for women as well. So
you're absolutely correct on all of the data that supports limiting red meat in your diet to improve cardiovascular health.
I feel like you as a provider go above and beyond and really try and individualize it for them. And not many providers have that energy or time to do that. But it's so important because quality of life is everything. So the more you can individualize it and customize it for people, the more sustainable those changes are for the rest of their lives. Last thing we'll touch on for today. So blood pressure. So can you talk to us about that a little bit? Most women don't even know what their level is, things that influence blood pressure, because it's not just necessarily their diet, it's also lifestyle and stress and all of these things, right? And so can you speak a little bit about what you've been seeing specifically in women with blood pressure and just some major recommendations you have for us?
Absolutely. One of the biggest driving factors is stress and poor sleep hygiene, and then also poor management of diet. You know, working moms, not even working moms, but women that are busy in the workforce and don't take care of themselves as we should because we're so busy taking care of somebody else. So some of these women that will come into the office, if they don't have other comorbidities and they're strictly coming in for blood pressure management, some of the things that we find are the biggest triggers are stress, right? Stress is one of the biggest triggers. Poor sleep hygiene, poor diet, not having a routine that is something that is sustainable every single day. There's working moms. There are moms that are at home. There's a lot of stressors in our life. Unfortunately, we live in a world that's full of stressors right now. And what I try to do is not have them focus so much on the number to begin with, but understanding the lifestyle changes and understanding their behavior modifications of what they need to do and adapt this first. So I think it's about understanding your individual patient, hearing about their routine every day, emphasizing the importance of low salt diet and sleep hygiene and exercise to improve all of that. And then once you get to these behavior modifications, if you still see that your blood pressure is elevated, then there are some other medications that we can recommend at that time. And again, that is something individualistic that will change based off of comorbidities and how high blood pressure is to be able to decide what recommendation you're giving.
I mean, it's scary, right? Like 1 in 2 women, and it's called the silent killer for a reason. And not many women know what their blood pressure should be. And more often than not, there's not really symptoms that we feel that coincide with elevated blood pressure. So it's kind of that mentality of like, I feel okay, but like the damage is being done inside. And
Correct.
That's scary when it's 1 in 2 women who have this.
Damage can occur when that blood pressure is persistently elevated without being treated, maybe not that high, but intravascularly you are seeing those changing of the endothelial lining and everything as well.
Exactly. And like old school thoughts being like, okay, my blood pressure's high, like I'll stop adding salt or I'll choose some low sodium options. Like, no, it is so multifactorial. Like you were mentioning, it's okay, well, how are you sleeping? And they're like, not well. I get like 4 to 5 hours a night. Takes me a while to fall asleep, or I wake up often. I have trouble breathing at night. And if they're a little bit overweight, of course, like sleep apnea, which a lot of it's undiagnosed. And if you're carrying around this excess weight, you're at higher risk for that. And shocking, right? Like hormones with women, so perimenopausal and menopausal, we see sleep apnea rise. And there's just so many other factors that can be driving that blood pressure. So these days, it's not just a simple fix of like, yeah, cut your sodium back. Like, no, you need to address multiple areas that are driving that up.
How many patients come in and say, I don't use a salt shaker, but then you find out everything they eat and how much sodium is in all the food and the takeout food and the restaurant food and the pre-prepared food, the frozen dinners, you're high in sodium. Those people think that, because I don't use a salt shaker, I'm eating low salt. That's not the case.
Exactly. And like now we've learned more information. Like it's not just about restricting that. You have things like one proven kind of dietary therapy that I've lived by for my hypertensive patients is the DASH diet, like the dietary's approach to stop hypertension. And it's not just about limiting sodium. Like we need to think of what we can also add to benefit from that. Potassium, magnesium, like all of these things can help with that too. So we just kind of need, as women, need to like take a step back and be like, oh, I actually need to approach quite a few things. It's not just one thing, quick fix, and we're good. And can you just give us some guidance so women do know and they're aware, what should their blood pressure be? Like, what is a good target range?
Less than 130 over less than 80 is the target range that I would like all women to be at. I think that's very realistic. Old guidelines would say greater than 120 and greater than 80 diastolic would be evidence of high blood pressure. And you've seen over the years that those parameters have changed a little bit.
Okay, thank you. And as we wrap up today, as a cardiac specialist, I kind of just wanted to get your opinion overall just on the role of GLP-1s, especially over the past couple of years, as we've learned more information about it, including long-term effects. Can you give us your opinion on who is the ideal patient, who benefits from this, and things like that?
The ideal patient for a GLP-1 is a patient that has known cardiovascular disease, a patient that has non-revascular cardiac disease, somebody who has weight loss problems despite being on great medications, being a diabetic, uncontrolled diabetic, adding in the GLP-1 to assist with weight loss. We all know what weight loss does in the body and what it does to heart health and what obesity does to patients that have coronary disease. Diabetics can't decide that they're going to eat different for a day, just like patients that take Ozempic do, or patients that take some of these other GLP-1s do. These patients are a select cohort that are taking this medication to lose weight in addition to their other medications to also control their diabetes. So without the presence of diabetes or coronary disease, we don't recommend GLP-1s. GLP-1s are also really prevalent for patients that are awaiting cardiac transplant. If their BMIs are greater than 50, they're not able to get on the cardiac transplant list. Sometimes we've seen that these GLPs have induced heart failure. So we're also very cautious on making sure that the GLP fits that patient. I would caution patients that do not have cardiovascular disease or diabetes away from the use of GLP-1s, and I would focus on lifestyle modification.
Love that. Thank you so much. I really appreciate all of your time and wealth of knowledge that you've shared with us today. I will definitely leave some detailed notes about Elizabeth in the notes for the episode. So thank you so much, Elizabeth. And thank you, everyone. I hope you have a great rest of the week.
Thank you for having me.
If you're ready to invest in yourself to become the healthiest and happiest version of you, head over to my website, thelifestylepa.org, to learn more about my 3-month lifestyle program, where I offer a very personalized, whole-body approach to optimize your health. In addition to your 1-hour initial consultation, we have 30-minute bi-weekly Zoom visits. You receive my 45-page lifestyle handbook, lab work interpretation, unlimited communication and support through a secure messaging platform, 3 months of meal plans tailored to your needs, and guidance on mastering the 6 pillars of lifelong health: nutrition, movement, sleep, stress management, positive psychology, and social connections. I can't wait to connect with you and help you to truly optimize your health once and for all.